Hello, my name is Ian McCall, and this is a video in the Dermatology for Dentists and Dental Students series. We're going to look tonight at the drug causes of oral problems. Now, you can look at either specific drugs themselves and some of the oral side effects that they can cause, or you can look at some of the diseases. Let's look at the diseases first. There are a few classic oral drug-induced diseases, and these include erythema multiforme, especially the Stevens-Johnson variant. Now remember, erythema multiforme is the commonest cause for it is in fact secondary to a herpes virus infection. But the more severe variant of erythema multiforme, otherwise known as Stevens-Johnson, certainly can be drug-induced. And the thing about the Stevens-Johnson variant is not only do they have the target lesions on the lower legs and the palms of the hands and the soles of the feet, but they've got mucosal involvement. So they've got involvement of the lips, the inside of the mouth, and involvement of the eyes, the conjunctival surfaces. So mild erythema multiforme just has the skin lesions, the target lesions. Stevens-Johnson variant tends to have the oral and the eye mucosal variations as well. Then you can get a fixed drug reaction. Now, this is where you might take a drug such as, say, a non-steroidal anti-inflammatory, and you only take it intermittently. And when you take it, within 24 hours of taking it, a rash comes up. Usually it's a solitary lesion, sometimes a blister. And it classically occurs on mucosal surfaces, especially the lips, and also on genital surfaces. So, fixed drug reactions, they flare up, settle down. They can leave a bit of hyperpigmentation, but when they occur in the mouth, they'll present as a red area that may ulcerate. Of course, a recurrent red area that ulcerates on the lip tends to get diagnosed as herpes, as recurrent herpes simplex. But a fixed drug reaction will do the same thing. So if you get a recurrent lesion in one area, then it's generally either herpes simplex or a fixed drug, unless some other localized contact cause is responsible. So we've got erythema multiforme, we've got fixed drug reactions, and the third disease that commonly is seen in the mouth and drug-induced is lichen planus. Now remember, we've mentioned lichen planus already. The most important thing if you see, and if lichen planus is just confined to the inside of the mouth, is to consider a drug reaction. And the particular drugs that will do it will be the ACE inhibitors and some of the drugs that are used in epilepsy and some of the beta blockers. They can all cause a lichen planus-like reaction in the inside of the mouth. So the diseases, erythema multiforme, especially the Stevens-Johnson, fixed drug reaction, and lichen planus. If we look at the drugs themselves, then certain drugs cause certain classic changes in the mouth. The tetracyclines in any child under the age of 10 will cause a yellow-brown staining of the teeth. This is because the enamel is contaminated by these drugs. And unfortunately, it's a permanent problem. Fluoride supplements will also cause stained teeth if there's an excessive amount of fluoride given. Hydroxychloroquine is a drug that's used in the treatment of lupus, but it can cause a pigmentation in the mouth. Minomycin can cause pigmentation in the mouth as well, but minomycin is a tetracycline antibiotic, and it's typically it's given in relatively low dosage for acne, but it used to be given in much higher doses for cystic acne, or the other type where you see the pigmentation is patients who have rosacea, because rosacea tends to be a very chronic disorder, and so they tend to be taking the minomycin for a long time. And it's those patients with rosacea, which is a red flushing of the face with papules and pustules, but they don't have any comedones, they don't have any blackheads. So they tend to be on minomycin for a long period of time. You get this accumulation of it, and it's deposited in cartilages and deposited in mucosal surfaces and in the skin. It gives a sort of slate grey type pigmentation. Methamphetamines these are, it's the fancy name for ice, which is one of these drugs of addiction that people take nowadays. And ice can cause severe caries in the inside of the mouth. I think it's partly the acidity that does it. But check that up. Just the degree of carious deformity that you can in fact get if you're taking ice. Then you all know about the bisphosphonates, the drugs that are used in osteoporosis. Unfortunately, in some patients who are on them and who have dental extractions, especially if there's any bone damage, they can get osteonecrosis, and very significant osteonecrosis. So this is a bit of a worry. If you're having to do dental extractions in patients on these drugs. Then, there are all the oral manifestations that you'll get, the oral problems you'll get with cytotoxic drugs. Cytotoxic drugs just hit rapidly dividing cells. So they'll hit the lining of the gut, the lining of the inside of the mouth, blood and liver, because these are all rapidly dividing, have rapidly dividing cells. So you get a variety of intraoral problems from cytotoxic drugs, usually erosions. Of course, you can get candida with all that damage. And a drug called adriamycin can give pigmentation in the inside of the mouth as well. We've talked about the ACE inhibitors and lichen planus, and the non-steroidal anti-inflammatories giving fixed drugs, but the fixed drug reaction, particularly in the lip. And then, you've got the dry mouth syndrome from a whole variety of drugs. And the consequences of a dry mouth: increased incidence of caries and periodontal disease. And of course, this will happen with antidepressants, antihistamines, some cardiac drugs, anticholinergics. These are drugs that affect acetylcholine, so they're used in bladder incontinence. They're sometimes used for excess sweating as well. But these drugs will cause dryness in the inside of the mouth. And of course, if you're taking these for a chronic condition, then you end up having a whole series of dental problems because of the dry mouth syndrome. So let's have a little look at some of these images here. Now, this is someone with erythema multiforme. You can see the ulcers, the erosions and ulcers that they have here. And if we're able to look inside the mouth, you'd see damage to it. Look at that tongue. There's some erosions occurring on the surface there as well. You can see that's red and inflamed and eroded on that non-vermilion side of the inside of the mouth. So this is the picture you'll see with erythema multiforme, and this was a drug reaction to trimethoprim, sulfonamide. It's usually used for urinary tract, Septrin and Bactrim. But these are drugs that can commonly cause Stevens-Johnson. If we had a look at this person's eyes, they probably have inflammation of the eyes as well. Here's just another picture of erythema multiforme. Not the greatest picture there, but you can see the erosions and the ulcers here. You can see the damage to the tongue in this condition as well. Another example, you can see the sloughing here. That's a sort of devitalized lining to the inside of the mouth. You can see the erosions that are occurring there. You can see it on the upper lip here too. That gingiva is affected. So erythema multiforme can give quite an erosion. It's one of the inflammatory conditions that can give a desquamating gingivitis as well. This was a fixed drug reaction induced by a non-steroidal anti-inflammatory on the surface of the tongue. This will heal, because usually these drugs are only taken intermittently. They're not taken all the time. That's the thing about fixed drug reactions. And so you might go 2 or 3 weeks and then take it again, and bang, you'll get exactly the same thing coming up in exactly the same area. The lips are also commonly involved with fixed drug reactions. This is erythema multiforme. That's your typical target lesions. See here? That's the center of the target. You can see that's almost threatening to form a little blister here, and that's because in erythema multiforme there's immune attack, lymphocytic attack at the dermo-epidermal junction. And in the areas where that attack's greatest, a degree of separation occurs, and so you get a sort of blister threatening to form in the middle here. and some inflammation around the outside. So these are the target lesions. These are some other more classic target lesions. I think this was, looks like over the shoulder, doesn't it? Anyway, usually it's on the lower leg that you'll see these. And this was part of Stevens-Johnson involvement of the surface of the lips, the inside of the mouth here, erosions and crusting having occurred, and the patient would also have involvement of the conjunctival surfaces of the eye. And what else do we have? This was lichen planus. We said before, remember, if you've got severe lichen planus in the inside of the mouth and it's mainly there with very little in the way of skin involvement, always think of a drug as a cause for this. And that's a very severe erosive lichen planus. That sort of patient would need oral steroids to try and settle this. You wouldn't get away with any topical therapies trying to settle a lichen planus like that. So these were the main things that I wanted to talk about here. We'd go back to the, bear with me just while I change this around. So these were the main issues that I wanted to talk about with drugs. There's more than this. Just remember these three diseases: erythema multiforme, especially Stevens-Johnson, fixed drugs, and lichen planus. Remember the dry mouth and the various drugs that can do that. There's more than this. Look them up. And then these particular preparations and the changes that they'll induce, the reactions that they'll induce in the mouth. Thanks very much.